So if I can take some questions, Reka, I think there is one question for you about prolonged infusion. When were TDM samples collected? And do you do TDM for antifungals? And do you foresee health economics evaluation in your next study?
Yeah, great questions. For prolonged infusions, we prolonged them over 3 hours. So we collected samples just before the next dose. And when we actually did have one patient that we changed to continuous infusions in for Kefipine, and that was spot samples after
How
24 hours of changing. So at the 24 hours from the dose change. So that was for prolonged infusions. And do you do TDM for antifungals as well? Yes, we do TDM for antifungals. We do for all the azoles. We don't do for echinocandins.
And so for Aaron and Reka, so is 60 to 80% above MIC no longer applicable? Should we all use 100% of time above MIC for from now on, or just for ICU or sepsis patients?
Do you want me to answer that, Aaron, or do you want to take that? What do you want to do?
I'll just quickly throw my 2 cents in, and I'll be very interested in your answer as well. But my I really enjoyed the paper published by the Belgium group from Dr. Dace about the maximum tolerated dose. I think that it's well described that the higher the exposure means that we can suppress the emergence of resistance. We also know that we do TDM in blood. We don't look at the infection site, and often with our beta-lactam antibiotics, when we look at lungs or in peritoneal fluid, for example, we know that the exposure at the site of activity is anywhere between half or to 1/5 that of the corresponding blood level, not even accounting for the unbound fraction. Higher, I think, as long as it is tolerated and monitored in the appropriate context, both for efficacy and for adverse events, higher is better. We know also that the higher the exposure from as early as 2014 with the DALI study, that if you achieve 100% time above MIC, you improve clinical outcomes. If you were less than 50%, it wasn't as prominent, but still better than sub 50% time above MIC. I think at least the minimum would be 100% time above MIC, probably higher. But Dr. Mangal, I'd be very interested to what you think about that as well. Controversial question. I like it.
Yeah. Look, I agree with what you said, Aaron. I think 100% time over MIC would be absolute minimum that I would use in a very sick patient in ICU. Um, 4 times over MIC, I think that's a little bit controversial. When we did our study, we went up to we set up 2 to 4 times, but we ended up using 2 times. With Kefipime particularly, I think that's a problem if you're looking at really high concentrations over a period of time. The patients are at risk of neurotoxicity. So yeah, no, I agree with all your points. I think 100% time over MIC is good. Um, and 1 to 2 times over MIC if they're profoundly septic, have deep-seated infections, difficult to reach sites, is something that I would also agree with. On a side note, Pascal, I saw your question about health economics. I think that's a really important thing, particularly if you're looking at scaling dose optimization across, like widely, across resource limited settings. And when I say resource limited settings, I'm also including Australia because not all centers have access to TDM in a timely manner. So I think health economics evaluation, just what with that and with the dosing software, which is probably easier to access anyway, because if we all have smartphones, we all have access to IT in one way or form in Australia, then that'll be good. Even in sort of resource limited settings outside of Australia, there is access to a computer. So I think, looking at dosing software and health economics is a really good thing to do, because not everyone may have assays accessible to them. And they don't have assays accessible to them in a timely manner.
Thanks, Aaron and Reka. So maybe if I can have one more question. So, Jiao, how does your organization decide which patients were eligible for caspofungin TDM, and what PKPD target did you aim for?
Yeah, this is really a good question because this is what is actually we found out is also although we have a very high numbers that we are testing, but actually for the antifungals it's not that good because I think it's still on the clinic. The physicians is the sometimes because they have used this for a very long time, only in case they have some faced and that they have some adverse react on clinic, then they will think about to doing the TDM other than just regularly doing the test. So this is, I think, is mainly about, and also there's a problem is because when we are using, especially for the hematology patients, they're using for a very long time, and only in case when they're sometimes the patient is falling in some problem and they're not very react very properly, so they are thinking about it's about the dosing problem or about the combination problem. So that's the I think it's why they have not less, and also we have the barriers because the feedback is quite late actually. Sometimes we have just test a report to twice a week. I think it's also a problem for them. They cannot just get there very properly. And also we have the targets like we're using the a this is also the targets about the targets we're using is usually for previously we have the studies about the PKB targets like AUC minus and MyCH over 20. But this is also a problem. It's because then you have to take quite a lot samples for a patient, and this is sometimes it's not very acceptable for the patients for the physicians. Also, I think it's the problem.
Okay, we've come to the end, unfortunately. So, firstly, I would like to thank our speakers, Jiao, who joined from China, and then Rekha, who shared interesting results, fresh from the Alvin results, and Aaron, who shared the results of Road and now is going to proceed with Road RCT. I would also like to thank the audience, and I would like to thank the sponsors, CRE Respond, UQCCR, and also University of Nîmes. So I hope to see you again in the upcoming CRE Respond Education Seminar. Thank you, everyone. Thank you so much. Thank you.
Thank you. Bye.